participate in this reputed conference. So just to get straight to today's presentation, unless anyone have any other question for me before the presentation. So if there's nothing, then let me just quickly share my screen. Can everyone see my screen?
Yes, we can see your slides. Perfect.
Oh, okay.
Yes.
All right. Thank you very much. Okay.
Please.
Yeah. So today's talk is on a new statistical model approach we have actually developed for survival analysis of cancer patients, and then this approach was actually proposed making use of multiple myeloma cancer data, but it was actually proposed for use for all kinds of cancer diseases. So this research work was actually done by myself and then my advisor and a distinguished professor in the University of South Florida over here. Yeah, so the idea of proposing this new statistical modeling is the fact for survivor analysis is the fact that we know Cox proportional hazard model have been the commonly used model for survivor analysis, and then also that of the Kaplan-Meier model for survivor analysis. But there have been several limitations regarding the use of Cox-PH, and some of the limitation is the fact that most researchers use the Cox proportional hazard model without satisfying the assumptions. They just give us the output, and it's hard to actually believe the findings. Then also the fact that finding some interactions using Cox proportional hazard sometimes is very difficult to actually come by. So we try to, and then Cox proportional hazard is not a parametric approach to survivor analysis. It's actually a semi-parametric approach, just like the Kaplan-Meier survivor analysis, which is a non-parametric approach. But as we all know, a parametric approach is always robust and efficient to use as compared to either non-parametric or semi-parametric approach. So in this research study, we actually adopted a parametric approach to survivor analysis, which happened to have proved to be more efficient and robust as compared to the existing approach, and most importantly, the Cox proportional hazard approach. So just to go straight to the presentation, this is going to be the presentation outline. So there will be the research question and then objective, some brief introduction, the analytical approach, the research, the results, conclusion, recommendation, and then some research contributions. So this research study aims at finding answers to the following questions. So it says, what are the individual risk factors that contribute to the survival time? Are there interaction of risk factors that contribute to the survival time? Given the risk factors and interactions of a given patient, how accurate can we predict the survival time? Then how much does each risk factor contribute to the survival time? Then how efficient or robust is the new approach method? So the main objective is to assess that assessment of ways to improve the treatment strategy of cancer survivorship using the multiple myeloma cancer data. So just something brief on the multiple myeloma cancer, which usually referred to as MM or MMC. Now it's called by the plasma cell becoming abnormal, which usually called the myeloma cell. Now, what you should know, some statistics about the multiple myeloma cancer is the fact that it constitutes 1.8% and rank among the top 14 cancer disease within the US over here. So the plot, the figure you see over here is the development of the multiple myeloma cancer. Now, on the data we use, the data was actually collected from West Virginia Medical Center, and then it constituted the survival times of 72 patients who were actually diagnosed with multiple myeloma cancer and treated with an alkylating agent. Now, for a risk factor, the number of risk factors that were recorded from the 72 patients were 16 risk factors, out of which 11 of them were continuous risk factors, and then 5 of them were categorical risk factors. Now, for the purpose of this study, we actually make use of 48 patients, and mainly because of some missing value of some of the patients whose data were not available for some of the variables. And then also, most importantly, since we are focusing on actually being able to come with an accurate statistical model that actually give a good estimation of the survival proportion of a patient, we actually focus on patient with uncensored data. So which means that data that were actually censored, with censored data could be data in which we don't know much about the patient. It's either the patient left the study before the study ended or the trial ended. So in order to avoid any of these discrepancies, we only make focus on patients who we have full information about them and then completed the clinical trial. So this is how the approach for developing this nonlinear statistical model was made. Now, first of all, we developed the model using the entire data. Now, the recent advanced way of statistical modeling is using part of the data to develop the model and then using the remaining parts to actually test the data. So in our case, the two approach was actually used, developing the model with the entire data. Then the second approach is developing the model with 80% of the data and being tested on the 20%. Now, the reason is the fact that we have a small data. So we would want to ensure that whatever model that we are able to develop is a model that is actually efficient and then passes any kind of test. So the model was actually developed. What you should know is this model is actually data-driven, which means given the model, we can actually input any data of any given patient, and we should be able to make a good prediction of the survival time of the patient. So these are the assumptions which are actually going to be satisfied given the model that was actually developed. The linearity, which means that survival time has to be a linear function of covariates or independent variables, and then including their interaction. Now, the residuals of the model must follow that's multivariate normality. Then also, we also have the homoscedasticity, the fact that the residual must assume constant variance. Then there should be none or minimum multicollinearity. We know multicollinearity actually can lead to overfitting of the model and then can affect the accurate prediction of any given model. So this is actually an assumption which has to be taken care of. Then also there should be no autocorrelation. So which means that the residuals must assume independent and identically distributed. So these are assumptions that actually was satisfied along the line of building this model and new approach for survival analysis. So part of the data processing which was actually adopted was transforming the data. So the data was actually transformed using the log transformation of the response variable, which is the survival time. And then also part of the risk factors or covariates, in this case, the independent variables were also transformed in order to actually suit the model we would want to build. And there's a special log transformation which was actually adopted. So having transformed the data, we move on to develop the data, and then the model selection, which was actually adopted, was a backward elimination model selection procedure in which we end up selecting the model which has the least AIC, which is the archaic information criteria, and then the root mean square error. Then the model which was actually found is the model which has a high R square as high as 87.41%. Now, this is the nonlinear model which was actually found given the model building process. So now, having found this model, now we move to the next step of being able to actually rank the variables within the model, which is very key. So we were interested in knowing the rank of each of the risk factors we actually identify and to know how much contribution they actually made to the survival time. Because what we should know is one, that a patient is being diagnosed with multiple myeloma cancer, the risk factors, they do not contribute equally to the survival time. So it was important to actually be able to rank the risk factors based on their contribution to the survival time. So we find X13, which is the Ben Jones protein in urine, at the time of the patient diagnosed with multiple myeloma cancer to contribute 30%, 30.57% to the survival time, followed by log blood urine nitrogen, which in other words, it is called the serum creatinine, which contribute 23.48%. Then we have the infectious, which is the third. Then the last contribution based on variables which were actually statistically identified to be significant in contributing to the survival time is age at the time the patient is diagnosed, which is contributing just approximately 1% to the survival time. So these are the rank. Now it is important to know the fact that these variables that are found are variables that are statistically significant. So which means there could be other confounding variables, but over here we are focusing on statistically significant variables in the model building. So having ranked these variables and now knowing the variables that contribute so much to the survival time, what it also means is the fact that if a patient visits the medical doctor and then the patient is diagnosed with multiple myeloma cancer, if the patient is found to have, let's say, Ben Jones protein, then we know Ben Jones protein could eventually contribute to about 30.57% of the survival time of the patient, which means the patient needs a critical treatment in order to facilitate the process to increase the survival time and to prevent the patient from dying sooner. So now, the next step of building the survival function using our approach is bootstrapping. Now, the bootstrapping method was actually necessary to adopt because we know we actually use a very small data of 48 patients. So we wanted to bootstrap to see how the model behaves and how much the model changes. So we bootstrap 300 or more, we resample 300 or more out of the 48 patients with replacement, which means it was done randomly. Now, the bootstrapping model resulted into an asymptotic statistical significance of the coefficients. So giving us an R-square, which is an increased R-square of 91.16%. Now, this is the, below over here is the resulting bootstrapping statistical model, which was actually found. And this model is actually not different from the previous model. The coefficients of each of the risk factors are almost the same. So it is important to know the fact that the model actually passes any amount of patient we have beyond 300 patients or more, and that is giving us a high degree of R-square. So now we have to validate the model and then to see how much the model does in terms of its prediction. So now to do that, we actually, remember I stated the fact that the model was built using the entire data, and then subsequently it was actually built by adopting the training and testing technique. Now the prediction from the entire data, which was the model which was developed, when compared to the survival time, the original survival time, gave us the accuracy of 0.943, which means 94.3% accuracy. Now using the training and testing technique, we are getting an accuracy of 0.93, which is 93%, which is actually not too different from when the model was developed using the entire data set. So now, having justified the accuracy of prediction of the model, now we move on to actually performing some parametric analysis on the predicted survival time. is actually to enable us to develop a survival function which will mimic the survival function of the Cox proportional hazard model. Now, by performing the parametric probability distribution on the 300 predicted survival time, we find this survival times to follow the log 3-parameter log normal probability distribution, and its PDF is given as stated over here. So now, how accurate is the distribution we actually found? That the parametric distribution we found for the predicted survival time. We tested this using the Kolmogorov, Smirnov, the Anderson-Darling test, and then the chi-square test. Now, all these tests gave an R-square, higher R-square, which actually indicate the fact that the distribution which was actually found for these 300 predicted survival time is valid. Now we proceeded, given that we've been able to find the distribution, we proceeded to the next stage of actually estimating the parameters within the distribution. We have the gamma, we have the mean, and then we have the sigma, which is the location, the scale, and then the shape parameter. So these parameters were actually estimated using the maximum likelihood parameter estimation. Now, having estimated the parameters, we are able to actually find the make the prediction of T star. Now, what you should know is we already predicted 300 survival times. Now, how different is the 300 predicted survival time from the original survival time T, which is the 48 times we initially started with in the model building process? Now we made a comparison of these two times by comparing the survival time using the Kruskal-Wallis test, which gave us a higher p-value, which is also an indication that there is no difference between the 48 survival time, which is the original survival time, and then the 300 predicted survival time. So this gave us a justification for us to make a progress in building survival function. Now, this is the PDF of the 3-parameter log normal distribution, which was actually found from the 300 predicted survival times. So what is the importance of this PDF? This PDF is going to help us to be able to actually find the probability of an individual surviving between any two given survival times. For instance, we can find the probability of individual surviving between 20 months and then 40 months. So which is stated as follows. Then also, we make a step further to actually find the CDF, which is the cumulative distribution. Now we find the cumulative distribution by taking the integral of the PDF. Now by finding the cumulative distribution, we are able to come up with a phi, which is the phi over here you see is the standardized cumulative probability function. The standardized normal cumulative probability. Now, this CDF plot you see over here is going to help us estimate the probability of an individual surviving up to a given time T star. So for instance, we want to find the probability of an individual surviving up to, let's say, 40 months. Now, using this CDF plot, we are able to actually find the probability. Now, having been able to find the CDF, now the most important step, which we are actually looking up to, is finding survival function. So by taking 1 minus CDF function, we are able to find the survival function. So the survival function is that the probability of the individual surviving beyond any given time T. So given the survival function, which is 1 minus the CDF, we are able to find the probability of an individual surviving beyond, let's say, 40 months, which we can actually use this plot to find. Now, how accurate is this plot? Now we compare the survival function of this nonlinear statistical model to that of the survival function of the Cox proportional hazard model. Now, in estimating, the red line over here is the red curve represents the nonlinear statistical model survival function, and then the blue curve represents the Cox PH survival function. And you can see the nonlinear statistical model is giving a higher prediction of survival function than the Cox-PH. Now, to justify the how accurate the proposed model of performance survival analysis is, we compare it with the Cox-PH. Now, the proposed model gave us a R-square, which is a coefficient of determination of 0.9116, which is 91.16%. Whereas the Cox-PH model gave us an R-square of 85.3%. Now, also, we have an AIC. AIC is measuring the amount of information lost within the model, which means the least the amount of information lost, the better fit the model prediction. Now, we have an AIC of negative 65.72 for the proposed model, as compared to the AIC of 28.52 for the Cox proportional hazard model. So this indicates that the parametric approach actually is giving a better prediction and more efficient prediction of the survival time as compared to the commonly used Cox proportional hazard model. Now, so in conclusion, and with some recommendation, now there are several usefulness we can actually derive from this approach of survival analysis. Part of it is being able to predict the real values of the survival time of the patient, given the significant attribute, the significant risk factors that were identified, including the interaction time. Then also the fact that we were able to rank the various risk factors according to the percentage contribution to the survival time, which is very key given the kind of risk factor a patient is going to be diagnosed with. Then also we can perform some surface response analysis to actually maximize or optimize the survival time given the risk factors and then the interaction. Then there are also, we can generate some confidence interval for some statistical inferences for the survival time. Then we can also perform parametric analysis to predict the survival values and then also obtain the survival function. So now part of the contribution which is being made in this research area using this our new approach is the fact that we have proposed a more efficient and robust, a more effective, efficient and robust approach for cancer survival analysis based on parametric technique. Now there's a logarithm or flow chart which is actually telling us how our approach can be actually used in performing survival analysis. So first of all, you develop a statistical model which has a high R-square, and then also that satisfies the necessary or key assumptions. Then you have to validate the model. So the second step is to being able to validate the model, ensure the model have high accuracy, and then also the next step is to perform a parametric analysis and then obtain the distribution of the predicted values. So once you validate the model, you use the model for prediction. Once you've predicted the values, you perform some parametric analysis on the predicted values. Now, once you perform parametric analysis on the predicted value, now you actually ask whether or not parametric distribution exists. If parametric distribution exists, then we proceed to finding the cumulative distribution function, which is the CDF, and then subsequently finding the survival function. If no, the parametric distribution does not exist, then of course we still recommend the use of the non-parametric analysis or the semi-parametric analysis. In this case, the Kaplan-Meier for the non-parametric analysis, and then the Cox proportional hazard for the semi-parametric analysis. Now, a big takeaway from this proposed nonlinear statistical model for multiple myeloma cancer is we identify new risk factors not yet found in existing study to contribute to the survival time of multiple myeloma cancer. And these identified variables include infectious, percentage myeloma cell in the peripheral blood, fractures, platelets, and then also the interaction term, which I think is very key, which is the interaction between the white blood cell and then total serum protein. Now, the interesting part of this interaction is the fact that this interaction did not individually contribute to the survival time. But once they were seen as an interaction, they were found to be contributing to the survival time, which means by performing modeling, you cannot actually underestimate interaction terms. Then also future work on this will be assessing the risk factors of multiple myeloma cancer at each stage of the survival time. We have the cancer stage. The data that we actually obtained is a full data set. We did not actually include the stages. Now, we by assumption, we assume that at each stage come with perhaps different risk factors. So we want to assess the different stage factor analysis for this cancer disease in terms of their survival of the patient. Now, so here is some references on this subject area. So any question?
Thank you so much, Doctor. So if anyone has any questions, please ask. And Dr. Lohuwa Mamudu email address is available in our chat. Okay.
Okay, so if there is no question,
okay,
then
so
yeah.
Thank you so much.
Okay, so if there is no question, then I thank everyone. And again, thank you all for making it possible for me to participate in this conference. And I look forward to future conferences with you.
Sure.
And then,
Thank you.
yeah.